All right, good morning, everyone. Let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine Serious Communicable Diseases program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an infectious diseases and critical care physician at Emory University, Director of Outreach and Education here at the SCDP, and your host for today. Before we begin, please know that we will be recording this session, and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you'd like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we are able. If we don't get to all questions, we will post a recap addressing those topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of this session. Now, the presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. As always, we will start with the Region 4 SITREP, and this will be followed by our case and didactic presentations with moderated Q&A to follow. So now it's my honor to introduce our guest for today. Our case presenter for today's session is Dr. Anish Mehta, Professor of Medicine and Infectious Diseases and Transplant Infectious Diseases and Professor of Surgery. Dr. Mehta is the Chief of Infectious Diseases Service at Emory University Hospital and Emory Orthopedics and Spine Hospital, one of 3 co-principal investigators for the National Emerging Special Pathogens Training and Education Center, or NETEC, and the Emory lead for the Special Pathogens Research Network. Notably, Dr. Mehta was one of the first physicians to care for patients with Ebola and Lassa fever here in the United States, having served on the clinical team for Emory's Serious Communicable Diseases unit since inception in 2004. Next, I'd like to welcome our didactic presenter, Dr. Mary Choi, Commander in the U.S. Public Health Service and Medical Officer in the Viral Special Pathogens Branch at the CDC, serving since 2015. Following her initial medical training, Dr. Choi completed a fellowship in international emergency medicine training at Columbia University. She's a former Epidemic Intelligence Service Officer, or EIS officer at CDC, but prior to this, served as an emergency medicine physician at U.S. Army facilities, both in domestic and foreign locations. Most significantly, Dr. Choi has been involved and deployed in every CDC filovirus outbreak response since 2014, just a small portion of her extensive military and civilian field experience. And lastly, I'd like to welcome Ms. Trish Tennell, Director of Nursing at Bellevue Hospital and the Special Pathogens Program Nursing Lead. Ms. Tennell has had decades of experience as an ICU nurse, including firsthand experience responding to multiple special pathogen outbreaks, and as a national leader in special pathogens training and education. She serves as NETEC's Infection Prevention and Control Workgroup Chair, delivers NETEC technical consultations to facilities throughout the nation, and develops national guidance on special pathogens preparedness. Welcome to you all. And now to place this session in context, the Emory University Serious Communicable Diseases program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channels, and listservs. Here is the current HHS Region 4 Special Pathogen SITREP. First, to Rwanda, where the latest Marburg virus outbreak was declared on September 27th. The country has not reported any new cases since October 30th, and the last patient was discharged from hospital on November 8th, starting a 42-day countdown until the outbreak may be declared over. Total confirmed infections stand at 66 with 15 fatalities, and most of the cases were connected to healthcare workers at 2 Kigali hospitals. The 42-day countdown spans 2 incubation periods of the virus. Next, to Nigeria, where a concerning increase in Lassa fever virus infections continues. Though the case fatality rate appears to be slightly lower than last year, 16.9%, challenges remain, including inadequate funding for preparedness activities, poor health-seeking behavior in affected communities due to high costs associated with treatment, and egregious sanitary conditions in high-burden areas. As of October 27th, there have been over 1,060 confirmed cases and 175 deaths. And on October 28th, the Iowa Department of Health and Human Services announced the death of a middle-aged Eastern Iowan resident from Lassa fever at the University of Iowa Medical Center. The person had recently traveled to Liberia and is believed to have had contact with rodents leading to contracting the virus. This is the 9th imported case in the United States since 1969. No additional cases have been reported. Moreover, as the patient was not symptomatic during travel from Africa, the risk to the general public and fellow travelers remains extremely low. Next, in North America, H5N1 continues to spread. As of yesterday, November 20th, the CDC has confirmed 53 total human cases in the United States in 7 states from cattle, poultry, and wild bird exposure. The virus continues to be detected in wastewater, poultry flocks, and dairy cattle herds, and now in asymptomatic poultry workers. Because of this, CDC has amended their PPE recommendations and testing approach to include high-risk individuals. Person-to-person spread has not been detected, and the current public health risk remains low. Additionally, on November 13th, the Public Health Agency of Canada confirmed H5N1 infection in a teen in British Columbia, unfortunately causing severe disease in that individual. Genotypic sequencing has revealed that this is different than the virus currently infecting U.S. dairy cattle. No other human infections have been detected in Canada, and investigations are still underway. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu. And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level with this topic. They should be up on your screen now. The first question, how confident do you feel about implementing the Identify, Isolate, and Inform process as it pertains to Marburg virus disease? And number 2, how knowledgeable do you feel about the current state of Marburg virus disease? If the audience could please vote now. All right, if we could get the results up on the screen, please, for our panelists and for the audience. It seems for the first question, we have quite a range from not at all confident to completely confident. So our panelists certainly have their work cut out for them. And the same with the second question. It seems we have a lot of opportunity for potential education here, as well as for preparedness. So fantastic. With that, let's begin, and I'm going to turn it over to Dr. Mehta.
Thank you so much, Gavin, and thanks for the invitation to speak today. So I'm going to present a Marburg case. I will point out this is a hypothetical case, and just be warned, it's not a real case. So this is a 32-year-old nurse working in northern Florida who has decided to take a little time off from her usual work to help out with an international health agency that trains community healthcare workers in Rwanda. She is a pretty healthy individual, just has mild eczema. She, prior to travel, was appropriately vaccinated for COVID, influenza, hepatitis, DTaP, and typhoid. She did see a travel clinic who also gave her doxycycline for malaria prophylaxis. But she did stop taking this medicine halfway through her trip to Rwanda because she was having recurrent esophagitis symptoms. So her story for this case starts in mid-March, where she arrived in Kigali, the capital, for some training with this non-government organization she was working with. In April, she was then deployed to a district in the northern part of the country, close to the Tanzania border. Her work was primarily supporting healthcare workers, or community health workers, as well as occasionally supporting and training some of the nurses working in some clinics. She did report occasional episodes where she would help with patient care using her own gloves and masks that she brought from the US. In mid-September, she noticed a higher number of patients presenting with severe acute illnesses in one particular village that was within their catchment area. It was thought to be mostly malaria. Some of the patients, though, were not confirmed to have malaria. On the 23rd, 23rd of September, she returned to Kigali in preparation to return to the US. She met up with some colleagues from the same organization, and they all spent a lot of time together. Some of them did report, particularly those working in Kigali, that they were also seeing some increased incidence of acute illness patients over the previous 10 days. On the 26th, she flew back to the United States, and she started her travel back, arrived back in Florida on the 27th. However, on the 28th, she started to feel ill with some body aches, some mild headaches, some fevers. Just noticed that she didn't have a very good appetite anymore. Over the next few days, she began to worsen despite good hydration and symptomatic care at home. Then on October 2nd, she began to have rigors, some more nausea, and noticed a new rash on her abdomen, and then potentially spreading to her back. So she drove herself to a local emergency room in Florida, reported her symptoms and travel history at the triage desk, reported no sick contacts, no animal exposures, and no sexual activity. She did also admit that she was not taking her malaria prophylaxis. The astute triage nurse, recognizing her symptoms being consistent with communicable diseases, moved her out of the triage area into an isolation room, placed her on contact and droplet precautions. At that time, her temperature was found to be elevated at 39.2. She was tachycardic and tachypnic. They did a rapid nasal swab for influenza, RSV, and SARS-CoV-2, which were all negative. Her labs showed a mild anemia. Her chemistries at that time were normal, except she did also have a mild elevation in her liver enzymes. A rapid malaria test was deployed, and that came back negative. During her course in the emergency room, she started to have some delirium and fatigue and worsening abdominal pain. An ID consultant was called to see her. The consultant felt that despite the negative malaria test, she may still have malaria, and given her delirium, she was admitted to the ICU and put on empiric malaria therapy. Thick and thin smears were ordered, as well as a repeat malaria test for the following morning. While this physician was eating lunch in the physician cafeteria, noticed a Han come across his phone announcing the first Marburg Virus Disease outbreak in the Republic of Rwanda on that following day. He immediately thought about his patient that he had seen yesterday, and decided to call the state public health hotline to relay the case information and the concern for Marburg. The case was discussed then with the CDC's hotline, their EOC, and in collaboration with state public health and the local clinical team, decided to send a blood sample to the nearest CDC Laboratory Response Network, or LRN site, in coordination with the Florida State Public Health Laboratory. On October 4th, the hospital and public health authorities were notified of a presumptive positive test. And at that point, Florida Public Health, CDC, the Region 4 respects UNC and Emory, as well as the clinical team at the hospital, started a series of support calls to help the local team care for the patient in that hospital. During those calls, the hospital decided to request a transfer of the patient to a high-level facility, and therefore CDC, ASPR, and NETEC had conversations to help assess where the best site to transfer that patient would be. On October 5th, the patient was transferred to the Region 4 RESPECT, or Regional Emerging Special Pathogens Treatment Center, located at Emory University Hospital, and it was admitted to our unit here called the SCDU. At that time, her temperature was a little better controlled, but still tachypnic and tachycardic. She had become mildly hypoxic. Her new symptoms were epigastric tenderness, increasing maculopapular rash across her abdomen, chest, buttocks, and her back, and her mental status continued to wax and wane. Her labs were significant for a low white blood cell count and particularly low lymphocyte count. Her platelets were also low, as were her red blood cells. She had further elevation of her liver enzymes and was found at this point to have an elevated amylase and lipase. Her chemistries did show significant decreases in her potassium and magnesium. Supportive care was initiated by Dr. Harris's team, including IV fluids with electrolyte repletion, good nutrition that we deliver in the ICU. And the clinical team decided to start IV remdesivir on the patient, which I should point out is not approved for the treatment of viral hemorrhagic fevers, but was thought to potentially help. CDC Viral Special Pathogen Branch, which had been involved right from the beginning, did relay confirmation with their specific test for Marburg virus. At that point, the patient was offered an experimental protocol for a monoclonal antibody known as MBP-091 through the NETAC SPRN Expanded Access Protocol. The patient consented and started monoclonal therapy on October 6th. This is just a hypothetical depiction of how the patient's liver enzymes would have done with good supportive care. And of course, we wouldn't have known if the experimental therapies had any benefit here. And this is just a sort of hypothetical graph of what Marburg virus PCR data from CDC viral special pathogens might look like. Remembering these are CT values, are inversely related to the actual viral load in the patient. And these were sent every 48 to 72 hours to CDC. By day 7, the patient was improving symptomatically. By day 14, the patient was mostly back to baseline, though still fatigued. However, the patient needed to stay in the hospital given still having positive nucleic acid testing. By day 24, she had a second undetectable test, and the discharge plan was coordinated between the clinical team, CDC, Georgia Public Health, and Florida Department of Health to get the patient back to her home safely. So key takeaways from this hypothetical case is that the patient, the primary hospital quickly identified, due to their preparedness and training, the risk for communicable disease and placed the patient in the appropriate level of isolation, protecting its staff. The clinical team was paying attention to public health announcements, specifically the CDC HON, and applied that information immediately to the patient. Public health and clinical experts were brought in immediately to help support the clinical team, and the pre-positioned experimental medical countermeasures allowed for the patient to have early access. Over to you, Gavin.
Thank you so much, Dr. Mehta, for that excellent case and for outlining all of the typical features that we see with Marburg virus disease. I also, while we're getting Dr. Choi's presentation lined up, just want to also appreciate the disclaimer there. We don't want to recreate a situation like in 1938 with Orson Welles' War of the Worlds radio broadcast, that was a hypothetical case, but it certainly elucidates many things which we will talk about. So with that, I'm going to pass it to Dr. Choi.
Hi, thank you. Are you able to hear me okay?
Yes, we can hear you and see your slides.
Okay, perfect. So thank you again for this invitation to speak today. I'll be giving the didactic presentation on Marburg virus disease. So, as everyone knows, Marburg virus disease is a serious disease in humans caused by infection with one of two viruses within the genus Marburg virus and then raven virus. The two viruses, although different, are very, very similar. Mortality rates really depends and ranges from 23 to 90% in the absence of early diagnosis and supportive care. And we know that the reservoir for Marburg virus is the Egyptian fruit bat, or Rosetus aegypticus. Since 1967, when the virus was first discovered, there have been 17 Marburg outbreaks, including the current one in Rwanda. Interestingly, the last 5 outbreaks have occurred in countries who have never previously reported cases, and they are listed here. There was one imported case of Marburg virus disease to the United States in 2008. It was a traveler who had visited a cave in Uganda that had been associated with other travel-associated Marburg cases, and she developed illness 4 days after returning from Uganda. She was initially tested for viral hemorrhagic fevers and tested negative. She had several different procedures and hospitalization activities done, and the diagnosis not made actually while she was in the hospital, but made retrospectively after she had learned that others who had traveled to the same cave had actually developed Marburg. And then repeat testing at that point identified that she had been previously infected with Marburg. With regards to the signs and symptoms of Marburg virus disease, they're listed here. The typical things that you see are fever, headache. Most people do complain of a very severe asthenia or fatigue that's well beyond normal. So anytime anyone's sick, you always feel a little bit run down. But what these patients report is severe fatigue and asthenia. And then the other thing that's important to note is that fever is not necessarily universally present at the time of detection. In people with Marburg, their temperature can fluctuate throughout the day, so it really depends on when you take their temperature. And then if you look at all these signs and symptoms here, other than perhaps the unexplained bleeding and bruising, which is a little bit less common, the rest of the symptoms can really be seen in any infectious disease, and particularly any infectious disease in countries where Marburg is endemic. And so it's really important to note that no sign or symptom is really pathognomonic for Marburg. And it really has to be a combination of epidemiologic risk factors as well as signs and symptoms and timing of those signs and symptoms. There tends to be a progression of illness when people develop Marburg virus disease. And so after the exposure to the virus, there's an incubation period. Again, according to the textbooks, is about 2 to 21 days. Typically, it's 4 to 17 days. During this incubation period, the person feels well, they have no symptoms, and they are not viremic, detectably viremic, and they cannot transmit the virus to others. So there's no asymptomatic transmission in people who are acutely infected during the incubation period. The symptoms start with what we call dry symptoms, which include fatigue and fever, headaches, joint pain. And the minute the person becomes symptomatic, that is when they can start becoming contagious to others. After about 3 or 4 days, the symptoms typically progress to a wet phase where people can experience nausea, vomiting, and diarrhea. People can develop a rash. It tends to be around day 5. In Equatorial Guinea, where we had some patients who were more light-skinned, Cuban healthcare workers, we were able to see that rash very readily. And people with darker skin tones, it may be difficult to see. And again, if people develop the bleeding, it's usually a late manifestation. And then sometimes people can also develop some intractable hiccups. It's important to note that as the patient progresses through their illness, they become more and more contagious. And so in fatal cases, death typically occurs about a week or so after the onset of symptoms. And the amount of virus in the body is highest at the time of death. And so, again, one of the reasons why, in countries that experience outbreaks, safe and dignified burials, where the burials are controlled and done in a very, infection prevention minded manner, is really critical to preventing additional transmission in the community. With regards to person-to-person transmission, in infected individuals, the virus can be found in all bodily fluids. including those listed here. Contact through broken skin or mucous membranes with the body fluids of someone who's sick or died with Marburg virus disease is typically how the person-to-person transmission happens. It is not airborne per se. However, when aerosol generating procedures like CPR and intubation and suctioning is done, that there is a risk of transmission there. And then again, aside, in people who are acutely infected, they are during that incubation period, they cannot transmit that virus to others. We'll talk a little bit later about sexual transmission that has been documented with Marburg in people who have recovered from the disease. So Marburg virus has been known to persist in the following immune privileged sites: the testicles and the aqueous humor of the eye. So there is documented transmission that has been that has occurred from a male recovered Marburg patient during the 1967 outbreak, and he transmitted that virus sexually to his wife. There was also a patient who recovered from Marburg virus disease that developed a uveitis, and they were able to identify the virus in the aqueous humor of the eye. And in the current Rwanda outbreak, the last two cases were said to be due to sexual transmission from recovered male survivors. Marburg virus is within the family of filoviruses, and we know that with the filoviruses, there are other immune privileged sites that are impacted as well, including breast milk, the pregnant placenta, and there's even been, for Ebola virus, relapse. So, some harboring of that virus in the CNS, where patients eventually developed a reoccurrence of their Ebola disease. Relapse has not been documented for Marburg, but because Marburg is also a filovirus, we always keep that in the back of their mind. With regards to the breast milk, also, there is breast milk testing in women who contract Marburg during their pregnancy or postpartum period. With regards to diagnostic testing, we have the BioFire Warrior panel, and it's able to detect, Ebola viruses, Marburg viruses, and these other pathogens listed here. Currently, there are 37 laboratories within the Laboratory Response Network and 13 regional special pathogen treatment centers that are able to test under this platform. And then confirmation testing is available at CDC. There is no FDA-approved vaccine. However, there is a chimpanzee Marburg vaccine that is experimental. It is recombinant chimpanzee adeno type 3 vector expressing the wild-type Marburg glycoprotein. It is a replication incompetent vaccine, and this vaccine is currently being used in a phase 2 open-label trial in Rwanda. And in that trial, they have offered pre-exposure vaccinations to minors, as well, minors like people who work in a mine, and then healthcare workers. And they've also offered vaccines to close contacts of confirmed and probable cases. With regards to treatment, there is currently no FDA-approved treatment. However, several treatments are in development, including MBP-091 that Dr. Anish mentioned, and then remdesivir has also been used as well. With regards to recommendations for clinicians, I think the first thing that we always ask is that when a patient presents with symptomatology that could be consistent with something infectious, to ask about that travel history. That is really kind of key to, raising the first little flag of warning, like maybe we're dealing with something that might be a little bit different than normal. And then if you are concerned that your patient may have MVD, to go ahead and isolate that person in a private room at the healthcare facility. And then following the PPE guidance that is available on our website. And then where possible, using dedicated and disposable medical equipment, limiting environmental contamination where possible. And then again, as I mentioned, for aerosol generating procedures, to use an airborne isolation room as well, and to limit the number of individuals that interact with this patient. So again, the critical thing is to collect that travel history, because oftentimes that's the thing that makes people think about some of the more quote unquote exotic diseases in the world. If you are concerned that your patient might have MVD, we always ask that you first notify your state, local, tribal, and territorial health departments, and to follow their protocols for patient assessment. We do this because it's something that the states have asked CDC to do, is to first give the initial referrals and the consultations, and leave it at that state and local health department level. Of course, we at CDC and Viral Special Pathogens Branch are always available as a resource as well, and that is 24/7 by calling the EOC. And we always have individuals that man that number 24/7. The other advantage that we have is that, oftentimes for most of these filovirus outbreaks, we do have either a country office or we have CDC staff in Atlanta who have actually traveled to that country for that outbreak response. And so we're able to really get very granular data and details on the outbreak status, and really can kind of help give a little bit of context to your patient's travel and risk factors. And then with that, I'll stop there. Thank you.
Thank you so much, Dr. Choi, for that excellent presentation. And I'm going to give both you and Dr. Mehta a break from speaking for a minute. You both have been speaking for some time, and we certainly appreciate that. But before we turn over for some questions, Dr. Choi, you mentioned on your last slide about involving your state and local health departments. I think that's exceptionally important to highlight once again. I would also point out that each facility in the United States likely has their own protocols for doing this, and so it's important for each person and healthcare worker to be aware of them. Often it involves the hospital epidemiologist or the hospital infection preventionist as well, which will lead to a further protocol involving the local state health departments, potentially CDC as well. So with bringing that up about infection prevention, I'm going to bring on our additional expert panelist here, Ms. Trish Tennell, a dear friend and colleague. And I want to discuss some infection prevention considerations here, Trish. We've had several questions about, issues with personal protective equipment, issues with identification of these patients. And Dr. Choi mentioned, I think, very importantly as well, that there's no sign or symptom that's pathognomonic for Marburg virus disease. And so with that, I'm wondering if you have any suggestions or thoughts on how emergency rooms can think about how we identify these patients and what we do when we do identify some of these patients, or the risks, given how infrequently our clinicians here in the United States may see Marburg virus.
Thanks, Gavin. That's a great question, and one that I'm very passionate about. What I want to say is that from current experience and working within my own facility, education is very key. You have to make people comfortable in the process of identify, isolate, and inform. And there's great resources out there for mystery patient drills that you can get through NETEC or at the Bellevue website, or contact our friends at Emory in Region 4 who are doing an excellent job. But you have to make people comfortable with the process. And this is not just during an outbreak. This is an everyday thing. Even during flu season, you want people isolated very, very quickly, and in an isolation room and in a mask. And that's going to help. And that should be habit, like washing your hands before and after seeing a patient. Identify, isolate, and inform. And I think PPE is always a big question, but I think one of the things that I'd like to say about PPE, and that's anywhere, is to make people comfortable in PPE and make them trust in your process, and also realize that you are doing the same tasks just in a different PPE, and not to fear it. And if you, I think availability, people always have questions, but if you learn to use what you have and you make your staff comfortable, that is going to help you with everything from identify, isolate, and inform to the PPE process. Thank you.
Yeah, thanks so much, Trish. You raised some fantastic points. We often think about PPE in the hierarchy of controls as being the last line of defense against some of these viruses, but I wonder, and perhaps you can speak to this, of its importance at the front line, right? And you mentioned about fundamentals. We often think that PPE may be intuitive, but I wonder if there's some challenges you can point to that it may not be, right?
Absolutely correct. I think what's really hard for people to comprehend is what is the most contaminated of their PPE, right? They need to realize what's the most contaminated, what had the potential to be the most contaminated, and to understand that we are there to advise them to take it off in a specific order. And I think that that is one of the basic fundamentals that people really have a hard time understanding. And that's something that I've learned within my own region, that once they realize this is the most contaminated part, that's why we're taking it off first, it starts to fall into place a little bit. I think that during the last outbreak of COVID, I think people got really good at taking off their PPE and understanding that. But I think now people are a little bit lax because they're not wearing it as consistently as they do. So I think that if we make partners within our emergency department and our floors that are going to help monitor this and help educate people, and it's just education, that I think that's really going to help with compliance. And it also will help with the transmission of any infectious disease that may walk in.
Great points. I mean, the fatigue is real, especially several years right after the pandemic of COVID began. Staying with this idea of highly infectious material infection prevention, I'm going to turn to the case that Dr. Mehta presented, because I think while it is a hypothetical case, it certainly illustrates some points we can discuss here. So there's a few questions about infection prevention, which we're going to get to in a moment. But Dr. Mehta, there was a question in the chat about treatment. And this, it is right up your expertise with the Special Pathogens Research Network. And I was wondering if you can expand a bit on what Dr. Choi mentioned with regards to MBP 091, when it can be given, how we can potentially obtain it. Can it be given without confirmatory results of a patient who may have Marburg virus disease?
Yeah, thanks, Kevin. Yes, and I should clarify, as I remember the hypothetical case better, the patient was offered MBP 091 prior to the confirmatory test, in which she was pondering whether to consent. And then once the confirmatory test was quickly delivered to us by CDC, she did sign. But it can be offered with a suspected case of Marburg. It is a single dose IV monoclonal antibody therapeutic that in animal studies has shown to be fairly safe, or very safe. And so we have really no apprehensions at offering it to anyone with suspected Marburg. The case is, the medication is available from MAP Biopharma through just like any other medication that is not approved, an emergency IND from the FDA. But the expanded access protocol that was developed with MAP through the SPRN was done so that we would have a open label study. The medication would be used in the same way in that protocol, and the same set of data would be collected from any patient that would receive that medication. But it can be potentially made available at any site in the United States. This protocol is currently only active at the 13 respects, and in addition at the NIH Clinical Center in Bethesda.
Fantastic. Thank you so much for that. Dr. Choi, I saw your hand up. Did you want to add something to a comment or question we've discussed?
Yeah, I just wanted to add, so we at CDC have also been having conversations with MapBio and BARDA, who supported the development of that monoclonal. And it is available readily, through MapBio and BARDA, and they have mechanisms by which to get that product to where it needs to be. They have also been very supportive of saying, if you really think that if you don't have confirmational testing, but you have a very high suspicion that the person has Marburg, then we are willing to go ahead and start the shipment process. And if in the end the person tests negative, that's fine. We'll take the product back. But they've been very willing to be very proactive. And just because of the logistics in terms of where the patient is and where the MapBio is where the product is being held. So, I think that amongst all the partners here, we can, try to expedite getting that product to where it needs to be across the United States.
Thank you so much for that, Dr. Choi. Those are great points. And I did also want to highlight, too, for our audience, right? These patients are never taken care of in a scientific or medical vacuum, meaning if there's a high suspicion or concern for patients, the treating team is never alone. There are significant resources throughout NETEC, throughout the region, throughout with our public health partners as well. So I did just want to highlight that too. I also wanted to highlight Dr. Sharon Carrasco had put in the chat for everyone here a link to a very important website here in Region 4 in Georgia. We will also be providing resources such as this in our post-session resources as well. Now, since we are on the topic of treatment with MBP-091, I wanted to perhaps have Dr. Choi elaborate on a answer that she put to a question in the chat with regards to any sort of challenges that Dr. Choi, you may have faced in the field, given your extensive experience in treating filoviruses. As we know, these patients are often co-infected with gram-negative infections, no signs, as we mentioned, or symptoms are pathognomonic, and so the odds of having infections that are not special pathogens are high. And I just wondered if you could perhaps elaborate or provide some sort of advice for those of us who may not see this as frequently as someone like yourself.
Sure. I guess I would clarify, just say that I've not treated these special pathogen treatments overseas. We've supported the treatment units, and we've supported the epidemiology, which is where the majority of our experience comes from. But there are co-infections that happen, for filovirus outbreaks, they often occur in countries where other diseases like malaria and typhoid are also very common. And so we have seen co-infections with malaria and Ebola, malaria and Marburg. In Equatorial Guinea, we had a fair number of patients who had co-infection with both Marburg and malaria. And so oftentimes when the protocols for the ETUs does include empiric treatment for malaria and other bacterial diseases while they're being evaluated and supported for possible Marburg infection. And then I think it's also important to note that, even in the United States, most of the time, 99.9% of the time, it's something else other than Marburg. But just because the person does test positive for malaria, there should be symptomatic improvement with malaria treatment, And if there is no improvement, then you have to ask yourself, is it possible that there's a co-infection here? And so it is important to, say, okay, great, person has malaria, we feel better. They came back from Rwanda. They don't have Marburg. Maybe. Go ahead and treat for the malaria and then reassess. And there should be symptomatic improvement. If there's not, then you do have to consider the possibility for, the filovirus that you were worried about initially.
That's a great point. Response to treatment is really important here. And Trish, I keep coming back to infection prevention, right? I mean, we talk about fundamentals in applying our infection prevention and PPE techniques for something like a filovirus. But really, you mentioned this already, right? Washing your hands. Some of these techniques can be applied to common things being common to things we see in the hospital every day.
Absolutely correct. And one of the things that I reinforce, and I know that my partners throughout Region 4 reinforce too, Our things that we do in our biocontainment units or our special pathogens units can be applied to everyday care isolation on the floor, hand hygiene, proper techniques in PPE, making sure people are in the correct isolation. So I think that I don't want people to be afraid of these. I want people to go back to the basics with infection prevention and control and apply the basics back to taking care of some of these high consequence infectious diseases, because you can do it. You just need to trust in the process and realize you have the basic knowledge and just apply it.
Great points. All right, Trish, we're going to turn to a big topic as well here, waste management. Waste management, right? So talk to us about waste management. There's a question in the chat about thinking about the transport of pathogens, thinking about protecting our laboratorians. What do we do with different types of waste? Give me your thoughts, please.
Well, for people that have known me, and a lot of these people have known me for about 10 years, I do love a little bit of trash talk. But I want to talk about, waste management when you're talking about a Marburg or viral hemorrhagic fever is category A waste, and to know the definition of what category A waste is. It's highly infectious. It needs to be inactivated. And one of the things that I can say that Didactic is coming out with some really great resources for that. So just a little plug commercial for our team that we're all involved in. But I think that it just goes back again to training and education, having people understand what the waste process is, having them understand what the PPE is. And I saw this question about the hypothetical question about the hypothetical case about the laboratorians and environmental services. And I just have to say, and I'm going to say it 1,000 times, it all goes back to education, because not only is it the healthcare providers, the physicians and the nurses that are taking care of this patient, their education, your waste management people, your environmental services and your laboratorians should have the same expectations about education and the same education as you would give your primary care providers in the room. So I think it's going back again to having them trust in their process, making sure that they have standards when they work, and them understanding again, because face it, we wear as a clinician, I'm in PPE more than probably my environmental services people are, right? And understand it, but making sure that they get the education. And again, going back to the basics with them about what is the most infectious, that this is the process for getting waste out of the room and storage and things like that. Because a lot of it, maybe it's just things that they do every day, but we may use a different terminology, and just getting that out there to them and helping them understand what's going on. I think people are apprehensive about the process until they understand about the process. And I will never use the word afraid, but apprehensive until they're educated and they understand. And the same with our laboratorians. They deal with specimens every day. But again, it is just understanding what the process and how it's different. And I think that I could just talk about this all day. I think one of the things people have to understand is you are doing the same process with a lot of things, but just in different PPE, right? I'm not going to teach you how to draw labs as an example or run your labs. What I'm going to do is teach you how to do it safely in the PPE that you're wearing under certain restrictions. And I think that that is really a good thing to explain to people and ensure that they understand what's going on.
Fantastic, Trish. Thank you so much. Just to expand on your thoughts about, resources about obtaining help from specific areas, Dr. Mehta, there's a question about the engagement of facilities who have different capabilities in our nation. And, I see your smile there too. I was wondering if perhaps you might be able to briefly address this with the framework of the National Special Pathogen System of Care.
Yeah, thank you, Gavin, too. Over the last 3 years, ASPR, NETAC, CDC, and other entities within the Department of Health and Human Services have created a strategy that actually builds upon the initial strategy that CDC had rolled out in 2015 with a tiered approach to preparing for these special pathogens. So back then there were Ebola assessment centers and Ebola treatment centers. Now we're calling them special pathogen assessment centers and treatment centers in addition to the RESPECTs. And that's in the NSPS, or National Special Pathogen System of Care, that you mentioned, Gavin. We are trying to rebuild a lot of that infrastructure that CDC had funded, but then the funding went away after the Ebola outbreak ended. So here in Georgia, a lot of that system was maintained. In Georgia, Department of Public Health has different levels for these Ebola, or now special pathogen treatment assessment and treatment centers. But we want to see that in all the states, all 50 states and all the territories in the United States, into a comprehensive network. The Joint Commission recently created some standards for emerging pathogens and special pathogen preparedness. And so all of those hospitals and healthcare facilities would automatically qualify to be level 4 facilities. And if you want more information on how we're trying to rebuild this network through the support of HHS, please go to the NETEC website and look for the NSPS tab, and you'll get a lot more information. And if any of your centers or sites want more information in person, we're happy to do webinars with you or informational sessions.
Thank you so much, Dr. Mehta. And just for the audience, we will again be providing these resources and websites when the post-session resources are made available. Dr. Choi, I'm going to now switch to a question for you as well. And from a public health perspective, what often comes up here is issues regarding quarantine, isolation, and potential discharge. And when I think about quarantine and isolation, I'm referring to potential for quarantining and isolation with patients at home, and then also thinking about how do we discharge these patients from the hospital. I was wondering if you could speak to that potentially.
Sure. I mean, maybe I can start with the discharge question. The discharge criteria, as Dr. Mehta has mentioned, for the filoviruses and rhinoviruses as well. We had imported Lassa here in Georgia, and well, they were transferred, but we typically ask for a 2 consecutive negatives, blood PCRs. The time frame between typically is 48 hours, but sometimes it's a little bit negotiable. What we have seen with some patients with both filovirus outbreaks and arenavirus infections is that often they're clinically improved before they become undetectable in the blood. I remember for the Lassa patients that were admitted at Emory, that it was quite a prolonged period of time where the individuals had completely come back to baseline health and yet continued to test PCR positive. So we are able to work with Emory, as well as, very importantly, the health departments, both in Georgia and the state of destination for this individual, to come up with a kind of a hybrid discharge plan. They could be released from the hospital because they were no longer posing an infectious risk per se for themselves and their family, but because they continue to be PCR positive in their blood, if there were to, for some reason, have, like, let's say, a car accident or something like that, then there could potentially still be an infectious risk there. And so we were able to work with the health departments to kind of come up with a plan of how to discharge from the hospital in a safe manner. For patients who develop acute illness and for whom we are concerned about a special pathogen, we feel that those patients should be evaluated and isolated in a healthcare facility, primarily because most of the time they don't have that special pathogen, and they likely have something else that's probably could potentially kill them much faster, like malaria, so delaying a malaria diagnosis or delaying treatment for malaria could be very detrimental to the patient. And so our stance has always been that individuals for whom you are going to test for Marburg, which means that they have a chance that they could have Marburg, also be treated in the healthcare facility. Just because they may not have Marburg, they may have something else. They probably need to be treated for that illness. But then because you think that there's a possibility for Marburg infection, you have to institute the infection control procedures for that to protect both that person as well as their potential close contacts and family members.
Appreciate that, Dr. Choi, and I'll just stay with you. We have a few minutes left here. When we think about viral hemorrhagic fevers, such as Marburg, such as Ebola, things like that, and we implement, funneling of travelers through specific airports, screening and identification of travelers through specific airports. Have you found there to be evidence that this is effective with these patients? Has CDC found that?
We have not. We started this back in 2014, and since that outbreak, we've intermittently have done funneling and screening of passengers through certain select airports, and then asked the public health departments to monitor. Thus far to date, we have not identified a Marburg patient or an Ebola patient in this manner. I mean, we did have that one physician who came back during West Africa to New York City, but then that person had already been checking in with their non-governmental organization, and they were identified in that manner. But so thus far, we have not. I would say that, some of those kinds of decisions are not, are kind of an interagency decision, and there are other factors that kind of weigh into those decisions. We do recognize that it is a heavy burden for the local and state health departments to do some of this monitoring, and we try to work with them as best we can to alleviate some of that burden.
Thank you so much for those honest thoughts and answers. We have just in our closing minutes here, Trish, I'm going to leave it with you to see if you have any lasting thoughts on Marburg virus disease, any specific advice or considerations for our audience before we do close.
Yeah, I think one of them is just to remember you're not alone, and that you've got great, amazing resources with Region 4. And I'll tell you that I've always relied on them too, as Region 2, for any assistance. So I want you guys to realize you're not alone. The resources are out there. Don't be afraid to call and ask. And they are there for you. And I don't know how much I can say this because I know with what has happened recently, and what I see as a potential in the future, just realize the resources are out there. You're not alone. Take a step back, hand hygiene, and think about how you're going to go into this. Okay, nothing is a rush. So that's one of my big things.
All right. And with that, we'll end our discussion. Thank you so much to our panelists. Thank you so much to our audience. Before we do officially close, I would like to again just pose an interactive poll question after participating in this session to our audience. Now, how knowledgeable do you feel about the current management and clinical guidance surrounding Marburg virus disease on that same scale of not at all knowledgeable to extremely knowledgeable? If you could please vote now. And while we are voting, thank you again to everyone. Thank you to our technical team here at the SCDP ECHO, Yasmin Thornton, our Project ECHO coordinator, outreach coordinator, and leader extraordinaire. Our planning committee was Sharon Van Aersdale, Anish Mehta, and Allison Claybar. Thank you so much. If we could see the poll results of that question, please. And it looks like our panelists have made significant inroads and provided some education for our audience, so we certainly appreciate that. This is very good to see. Of course, there are always more opportunities for education and outreach. We will be providing the slides, the presentations, recording, podcast, as well as post-session resources to our audience when this is made available as a podcast next week. For feedback and further information, including continuing education credits and the recording, please check the links here and on our website. We do look forward to seeing you again here soon. Thank you so much.